It's a pleasure for me to introduce Professor Cicinelli. Professor, he's a professor of obstetric and gynecology of the School of Medicine of the University of Bari, Italy. He's chief of the first and second obstetric and gynecology unit and director of the postgraduate school in obstetric and gynecology in Department of Science of Medicine and Oncology and Human Oncology in the University Hospital Policlinico of Bari. Professor Cicinelli is going to talk us about endometritis and going to make us an update about that. Professor, you have the floor. Welcome.
Okay. Are you hearing me now?
We can hear you perfectly.
Yes. Okay. I apologize. There was a technical problem. My browser, the Safari, didn't work. Then I had to change in Google Chrome, and now it's okay. As I told you before, it's a very great pleasure to speak in this meeting. And after the words, heard the words from Anthony, who told about the future of reproduction, and listen, the problem related to the quality of embryos is something wrong. There's something that we miss in quality of embryo, but of course, I think in my clinical practice, I'm convinced that we miss a lot about quality of the endometrium, because one of the major interest in my last year was on endometritis, and what is endometritis? I think that all of you know is a chronic inflammation of the endometrial lining. It's a pathology that could be seen easily by hysteroscopy. And it's a pathology that is unknown to most of gynecology specialists, and often is diagnosed only casually for different indications. Now, today, we still debate about the microbiome of the uterus, but most of people is convinced that data are consistent on the fact that the uterine cavity is not sterile. This dogma that was true until last few decades ago now is generally accepted now that the uterine cavity is harbored by bacteria, by a flora of bacteria, and that uterine cavity has a distinct microbiome. Recent study performed by the group from Carlos Simon and Immaculada Moreno showed that the uterine cavity is colonized by lactobacilli, and then that when this microbiota is altered, the functionality of the endometrium can be altered. The update, what's new about endometritis? Diagnosis. This is just to show you that you have always to think of endometritis when investigating, when looking patient for different indications, for infertility, for polyps, for dysfunctional bleeding, for submucous myomas, for Mullerian abnormality. So remember, you have to check the endometrium, not only the shape, not only the myomas, the nerve formation. We have to look at the quality, especially if you deal with infertility, if you deal with this bleeding, abnormal uterine bleeding. And the traditional diagnosis is based on histology and plasma cells. Today, we use the count of CD under 38, also known as Syntecan-1, that is a transmembrane heparan sulfate proteoglycan that can be detected by immunohistochemistry. And we can evaluate the number of these cells. However, when looking by this technique, we have to remember that in some cases the normal epithelial cells can express CD under 38, and so we can have false positive. Another problem regarding this marker is the fact that at the moment does not exist a consensus on how many plasma cells must be detected to make the diagnosis. And depending on the number, depending on the criteria, the prevalence of the pathology is show a wide variability in literature. These are the same concept that I just told you. Some authors consider 1 plasma cell per section, per HPF, for 10 HPF. So we need a standardization in this field. A new marker that that can substitute CD under 38 is MAM1. MAM1 is a oncogene expressed by multiple myeloma, and shows a very high specificity for plasma cells. And in the preliminary results, our results and the Sergio results too, we are trying to cooperate on this field. It shows better results than CD under 38. Another aspect is the important aspect in my experience, because it was the first way to detect this pathology is hysteroscopy. In this sense, also in this sense, we need a standardization. We need to share the criteria. The criteria for diagnosing chronic endometritis are the following. We have to look at hyperemia, focal diffuse. We have to look at polypoid aspect, addition, but whitish appearance. That means edema of the stroma in the follicular phase, but above all, you have to look at micropolis that are typical lesion and specific for inflammation. And these are some examples of this abnormality. And recently, we tried to reach a consensus, and by using a Delphi consensus technique, we reach an agreement among some experts, and we performed this RCT randomized control study involving expert and non-expert hysteroscopists, and we demonstrated that by using clear diagnostic criteria, the capacity of the hysteroscopy and the inter-observer variability is reduced, and the capacity of the test increases. What about the other techniques? Cultures. These are the typical bacteria that are at play in our experience, but with culture, there are common bacteria, but we have to consider that culture are limited by the fact that several bacteria are not cultivable. So we can get many false negative results. And very recently, we published, always with the Carlos Simon group, Immaculata Moreno, a paper looking at the capacity of the molecular microbiology, a different tool for investigating this pathology compared with traditional one, I mean hysteroscopy and histology. And the result of this test looks at is a quantitative real-time PCR looking at 16S and RNA gene that is typical for most common bacteria. So we can have a possibility to recognize each bacteria and to to perform to evaluate all the microbiome of the uterine cavity. And interestingly, the results of this study we can show you, yes, is that by using molecular microbiome study and this technique, we can get a concordance rate of roughly 80% with traditional technique. So we need only a specimen from the endometrium to make an evaluation of the microbial condition of the uterine cavity. Of course, we needed to confirm this result. We need to perform a randomized trial on the usefulness of this approach, but it's very interesting. Also because our impression, one of the limits of endoscopy is that probably we overestimate inflammation by endoscopy. This is, I'm not convinced that we overestimate, because we see that there is something wrong. But this opens the possibility a different kind of inflammation. I mean, chemical inflammation, viruses, and other infectious agents. So I think that it is a field open to new investigation and new findings. This is the test that are on the market. Similar results were get by different group. And today we are trying, there's some paper trying to define some microbiome for different conditions. Look, healthy patient, infertility, endometriosis, chronic endometritis, polyps, dysfunctional breathing, and cancer. So the idea is that the prevalence of some bacteria of different genera could be connected to some specific pathology. This is a new way to look at problem of our pathologies. So the inflammation of the uterine cavity plays a very important role in infertility, and this is a study from Moreno, result from Moreno group, showing that the blue bars are the normal endometrium, normal microbiome with lactobacilli, and you see LD, live delivery. When red is prevalent, it's not live delivery. This is very easy to see, is very informative. But why inflammation may cause infertility? Different mechanisms. One is the alteration in subpopulation of lymphocytes. You see a reduction in natural killer cells. And this is a very interesting paper from Kitaya showing that B cells, lymphocytes, B cells are very present in this pathology. And the problem is that lymphocytes are present not only in the stroma, but infiltrate also the mucosa, creating damage also to the glands and to the vessels. So the key points in infiltration is that it's altered, and this is prevalent with mucosal damage. Similar results are in terms of update, very recent paper from Chen group that confirm a alteration in natural killer cells, and also the expression of paracrine factor, interleukin factor. This is at the implantation window. These substances are altered at implantation window in women with inflammation. And a recent paper of ours showed that not only at the implantation window, but also in the follicular phase, gene related to the inflammation, proliferation, sex cycle regulation, and apoptosis are altered. In terms of proliferation, in terms of anti-apoptosis, and this, in our mind, may create a liaison, a relationship between inflammation and proliferative pathologies in terms of polyps, hyperplasia, and possibly also cancer. These are also additional data, very recent data that shows like desidualization is altered in case of inflammation. Very recent data this year showing that inflammation is only local. We have no signal in periphery. So this is not a systemic inflammation, it's only a uterine inflammation. This is a model, our model for showing the relationship between inflammation and impaired endometrial receptivity by expression of paracrine factors, expression of antibodies, delayed differentiation, infiltration, histological alteration, and gene and altered gene expression. So all concurring to determine to cause an impaired endometrial receptivity. And many papers in literature confirm that the chronic meningitis is connected with recurrent miscarriage. This is a paper of ours of some years ago showing that comparing to women with persistent inflammation, patients with cured inflammation had a large birth at the end of pregnancy, and of course McKean paper showing the same similar results. And this paper, very recent paper from Cuckoo, showed that even if we look, if we check at the miscarriage and we check at the residual decidua, in case of miscarriage, we found a higher incidence of endometritis in patients who underwent miscarriage. So the relationship is very strong, is confirmed by a number of studies. Looking at successes at IVF, similar results we can, this is a paper of ours showing that in patients who were cured, the results after repeated failure at IVF were successful. And similar results are from Zhong last year, other paper confirming this data. And this is also another recent paper showing that the presence of CD under 38, so the demonstration by histopathology or the presence of plasma cells is a negative prognosis indicator in patients who have previous embryo transfer failure. So again, look at the endometrial quality, and again, a very recent paper from Kitaya demonstrating that paper with repeated implantation failure have a different microbiome in the uterine cavity. This happens also in patients with unexplained infertility that when are cured can be confident to expect or can expect to become pregnant. And our model, our idea, as I told you before, is the connection of inflammation with pathologies that interfere with production. Inflammation is the basis for the...
Professor, 5 minutes.
Yes, I'm going to finish. This is a connection with addition, a connection with this is with the endometriosis too, with the polyps. When you have this kind of pathology, probably inflammation could be at play. And this is the result. The treatment of this pathology is based on antibiotics. We can have a different approach. This is a meta-analysis of people confirming that in a patient with repeated implantation failure, antibiotics therapy could improve results. And in literature, we can have two different approaches. One is that we use, and that is based on antibiogram-guided therapy, and but depending on gram-negative or gram-positive, we use ciprofloxacin or amoxicillin. in case of molecules with mycoplasma and neuroplasma, we use ursamicin or erythrocin. And in case of negative culture for bacteria that are not able to be grown in lab, we can use some CDC following CDC guidelines: ceftriaxone, doxycycline, and metronidazole. Different approach is a standard treatment based on oral levofloxacin 500 milligram and tinidazole 1000 milligram daily for 14 days. Recent paper literature show also possibility to make an intrauterine treatment with dexamethasone and antibiotics. And very recently, there is also the proposal of a substitution of microbiome with probiotics or microbial transplant of then the conclusion. The conclusion: chronic endometritis is a subtle, often missed, and highly prevalent, associated with reproductive insuccess, but not only. Consistent literature demonstrated that chronic endometritis impair spontaneous as well as assisted reproduction. Is common bacteria are at play, not chlamydia, not specific STD pathogens. May be easily detectable with hysteroscopy. Histology with C138 is now the gold standard, but probably we need a standardization, and MAM1 could be helpful in this sense, in this way. Endometrial culture, not vaginal, so vaginal culture are useless. Are able to identify only a little part of microorganism, and probably the biomolecular microbiome technique will be the future in this field, and adequate antibiotic treatment improves reproductive outcomes and other aspects related to inflammation like pain and like abnormal uterine bleeding. I finished. Thank you.